So chapter 17 is our substance use disorder, and this is a little bit easier. We've got them in three different groups. So we're looking at opioids, which we've mentioned already, stimulants, which we've mentioned, and depressants, which we've mentioned. So when we're looking at these use disorder, we want to think about the disorder problem, the tendency to abuse medications, etc. Why people do that. What are other things that we can do other than abusing medications? So consider that. And then you can scroll through some of the key terms I want to point out too that tend to be on HESI and NCLEX. This first one is that Korsakoff's psychosis. Korsakoff's psychosis is a syndrome of amnesia with confabulation. That means making up great stories associated with chronic alcohol abuse. It often occurs with Wernicke's encephalopathy, which is this one down here. This Wernicke's encephalopathy is a neurological disorder characterized by apathy, drowsiness, ataxia, nystagmus, orthomalacia. It's caused by a vitamin B deficiency secondary to chronic alcohol abuse. So we'll see, if you see one of these in a stem of a question, I want you to automatically think alcohol abuse. That's kind of where they're pushing you on that one. So it talks about why do we get into alcohol or why do we get into substance abuse and now calling it an actual disorder, and what happens when our body goes through withdrawal and some of our commonly abused substances. And again, we put them in those categories of opioid, stimulant, and depressants. It mentioned heroin being one of the top misuse there. So we're going to look at them in relationship to these major categories. So our first one is opioids, and we mentioned that one earlier. I think it was back in chapter 10, because it helps the brain not to feel any pain. It also gives you a sense of euphoria. So that euphoria is usually why people become addicted to opioids. The indications for opioids, usually it starts out okay. You're usually prescribed opioid for a reason, such as to relieve pain, to reduce that cough that I mentioned. It can also relieve diarrhea and to induce anesthesia. But then as we become more dependent upon it, as those physiological reasons decrease, that's when we might see that a patient was actually becomes addicted to those medications. Contraindications of these drugs would be drug allergies, pregnancy, respiratory depression, because this is going to be, it's our, remember our opioid was a CNS depressant. So as it depresses that, it also causes that respiratory depression, which also plays into a contraindication of asthma, and paralytic ileus. And that means where my gut's not moving well. We want to make sure that we avoid it with those individuals because it's going to further slow down that gut motility. So it could cause for severe problems with that paralytic ileus. Adverse effects that are associated with our opioids. In the CNS, we can see diuresis, meiosis, which is constriction of the pupil, convulsions, nausea, vomiting, respiratory depression, which we've mentioned several times. For non-CNS related things, we can see a release of histamine, which would cause vasodilation. That vasodilation will further play into hypotension. We can see constipation, urinary retention, flushing, and sweating. I would like to point out this box here, 17.2, to show some of the overall OD withdrawal that needs a formal detox to manage those symptoms. And then we can use meds to try to treat those symptoms, such as clonidine or methadone. Interactions with our opioids are going to be other CNS depressants, such as I usually think of alcohol as being one of our number one interactions there. We mentioned a few specifically, such as heroin, codeine, hydrocodone, morphine, or oxycodone are highly ranked on the substance misuse policy. Our next group under substance misuse medications are stimulants, and we talked about those when we talked about CNS stimulants. These are drugs able to increase or elevate mood, reduce fatigue, increase alertness by innervating CNS stimulation. If they do that, they're also going to increase your blood pressure, tachycardia, and can cause some cardiac dysrhythmias. It also causes urinary bladder sphincter contraction, so it's going to cause urinary retention. which might be helpful if an individual has enuresis or bedtime bedwetting, but otherwise it's going to make cause for painful bladder urinary retention. Treatment for our indications for our stimulants are it's used primarily to treat ADHD, which we talked about, narcolepsy, and obesity. Our contraindication are the same as what we mentioned earlier. So drug allergy, diabetes, cardiovascular disorders, agitation, hypertension, drug abuse, and Tourette's. Some of the adverse effects of our stimulants is it can cause an extension of that therapeutic effect, which would include restlessness, syncope, insomnia, talkativeness, irritability, and even fever. We can also see confusion, aggression, anxiety, suicidal ideation, especially if I have patients with mental illness. We can also see cardiovascular effects. And then when we have withdrawal, a patient can have death from convulsions or coma or cerebral hemorrhage. So we'd want to treat their withdrawal from our stimulants very supportively. Medications to note on this one in this umbrella would be cocaine, meth, amphetamines, especially any meds with psychoactive properties that impact the mood and behavior and cognitive processes and mental alertness. Then our last group on this one of disuse drugs would be depressants. They are supposed to be used to increase the GABS, which inhibits my nerve transmission in my brain, and that is indicated when I need to treat anxiety, induce sleep, promote sedation, or prevent seizures. It's contraindicated in my patients with drug allergies or dyspnea, airway obstruction, glaucoma, or porphyria. The adverse effects associated with my depressants would be an overexpression of those CNS therapeutic effects, which would be drowsiness, sedation, loss of coordination, dizziness, blurred vision, insomnia, and hallucinations. There's a good box here of the signs and symptoms and then the treatment of depression withdrawal. Our antidote for this one, for one particular thing, is that flumezicon. Let's see, where is that? Flumazenil, and we use that one to treat our benzodiazepine withdrawal. Some of our drugs that are listed in this area would be THC, CBD, benzodiazepines, alcohol, and then they can be used to treat seizures and induce anesthesia. A little note on alcohol, because it's under this umbrella, is to pay attention to the adverse effects of over alcohol consumption, such as neurological and mental disorders, which would include seizures, nutritional and vitamin deficiencies, one of the key components there, especially vitamin B vitamin deficiency, which can lead to that Wernicke's encephalopathy and that Korsakoff psychosis, especially when they use alcohol with other CNS depressants. Our treatment for alcohol abuse can be disulfiram. Let me see if I can find that one. There we go. Disulfiram. When we take that one, it's not a cure, but it causes intense flushing, head throbbing, nausea, some projectile vomiting, diaphoresis, hyperventilation, vertigo, and confusion with very little alcohol. Literally, like if the individual would take NyQuil, they would have a reaction to that NyQuil because of the alcohol content. Did want to point out on page 281, wanted to point out table 17.2. That mentions a lot of the different medication names, just so you'll be aware of those. Let's see. And then the last one in this chapter was nicotine. And I speak to nicotine about like I do with caffeine. I think the biggest concern with nicotine now is how they're getting it. So the nicotine causes that transient stimulation, and then it will lead into persistent CNS depression. depression. So we want to note that the overdose of that is usually symptomatically treated. We can treat it with activated charcoal. I usually think about how we're getting nicotine anymore. So if it's in the form of a pouch or something they're keeping inside their lip, how that's associated with oral cancers, throat cancers, overall mouth cancer. And then if they're vaping it, what we're seeing in the lungs, and you guys are going to see this in your practice for the next 20, 30 years, how those long-term effects are impacting their lungs. Again, roll to the bottom of the chapter. What do we need to assess when we're looking at an individual with a substance abuse disorder? What do I need to know to take care of them prior to giving medication or prior to helping them wean off those medications? What would be the implementation of using a medication to help them get off one of these medications or some sort of therapy for that? And then to evaluate their use. And to evaluate it, we want them to abstain from use of the medications anymore. And that wraps up chapter 17.